dental implant seminars, and the name bone evaluation. What is the bone? Programs approved by the American Academy of Implant Prosthodontics, Professor Sheldon Winkler. This webinar, bone. What is bone? And that's pretty much the question of the day. If anybody will ask you, what is the bone? The answer is simple. The bone is the organ like the lungs or liver or the heart or some other organs. It's a living vascular organ, and the description of this, it's a differentiated structure as a heart or kidney, consists of the cells and tissue and performing some specific function in the organism. Respond to any influence from inside or outside. And the law of the bone remodeling was described by Julius Wolff a number of years ago. It holds that every change in the form or function of the bone is followed by the adaptive changes in its internal architecture and external shape. Pretty much bone behaves like an organ. It reacts. In 1963, the studies of the famous Italian implantologist scientist Ugo Pasqualini, he demonstrated how the bone changes under the load. We're going to take a look at the bone, the classification of the bone, the lamellar bone, the woven bone. And Ugo Pasqualini demonstrated how the bone under the load changed from the woven bone to lamellated bone, and demonstrate this on those slides. Structure. What is the bone as in bone anatomically? The bone consists of the two different type of bone. It's a compact bone, which is a cortical bone, surround the mass of the trabecular bone. By definition, the two type of bone, by function and definition, can be identified according to the pattern of the collagen forming the osteoid. And here we have a woven bone, and here we have a lamellar bone. The differential of the woven bone versus lamellar bone. The woven bone characterized by chaotic organization of the collagen fibers, and this is a mechanically weak bone. When the bone is under the load, there's a different type of load, but under the load, the woven bone changes, and the woven bone creates regular, parallel in alignment collagen into the sheets, lamella, and this is a mechanically strong bone, and we're going to demonstrate this. If you'll take a look in the upper left picture, you'll see that this is how the woven bone looks like. Again, it's a poorly organized and poorly mineralized. On the X-ray, we can determine the difference between the lamellar bone and the woven bone. So the woven bone is the area which withholds no load, no any kind of load, and this is again poorly mineralized and poorly organized bone. However, the area of the bone which sustains some load becomes a lamellar bone, and you can determine just by looking at the X-ray, because this is a highly saturated with the minerals and much better organized bone with lamella. We can take a look at the clinical cases. In 1994, this was a part of the panoramic X-ray, which demonstrated failing tooth, and tooth was extracted and replaced with the bone graft. And however, at the area on the front of that tooth, anteriorly to the extraction sockets, there were two implants placed in 1994. And if we're going to look through 1994 to 2010, we can see that the bone around the implants has a very strong pattern, bone saturated with the minerals, and that's what presents mineralized, which is lamellated bone. And the area where the tooth was extracted and grafted with the autogenous bone, you can see that this bone doesn't look as strong, and it looks more like a woven bone. If you'll take a look behind in the area of the wisdom tooth, you might have noticed that there's like some kind of like as a cavern, which probably there is no bone inside at all. That where the wisdom tooth was extracted number of years ago, and this side wasn't grafted, wasn't loaded, and therefore the poorest quality of the bone would be in the area which is non-functioning at all. On the CAT scan, it's demonstrated how the lamellar bone formed around the implants under the load, and you can see very well developed and very well shaped lamellar bone around the implants in the parallel sheets of a lamella. However, in between, when the bone sustains no load, you can see the typical woven bone. It's like a cotton, poorly organized and poorly mineralized. Now we understand that there are two important types of the bone, the lamellar and the woven bone. And our goal and our successful goal would be to get this lamellar bone, as is demonstrated on the next slide, around the implant, and especially in the most critical area at the cervical area. Now with the CAT scan, with the 3D technology, determine this much easily, and we can assume that our clinical situation either success or not as success by looking at the bone surrounding the implant. Case presentation, we will take a look at how do we deal these days with treatment planning. How do we determine the quality of the bone based on number one, it's intraorally, and number two, we can utilize the CAT scan information in this particular case. When the patient like this presents to the office, pretty typical situations in New Jersey. I don't know how's it around the world, but we do get a lot of patients like this. Unfortunately, the dental health of this individual was like extremely neglected. So he came to the office as he's interested, what is it he can get done. By just getting the CAT scan, it's a very good communication tool. But for us, it's very important to do the intraoral examination to determine situations of the width of the ridge. We'll discuss this in detail. And the most importantly, we need to determine what is the situation with the soft tissue. And in this case, you can see that there is a lack of a keratinized tissue, especially on the lower jaw. The occlusion, it's a main factor which we can determine what kind of occlusion we're dealing with, what kind of occlusion we're planning to deal with. And the treatment plan would be including building up the occlusion to the occlusion which we want to have as a final result. Again, on the lower jaw, we can see the very narrow ridges, and we can see lack of the keratinized tissue. The loss of the vertical and the horizontal bone determined on the CAT scan, and estimated the remaining portion of the bone, and estimated the vital elements like nerve and the sinuses from the CAT scan information. And based on the information which you gather together, we do the study models and we do preliminary wax-ups or denture teeth setups. So we want to have the teeth. Again, I'd like to emphasize this. What is the implantology, the oral implantology? The prosthodontics, the final restorations. The patients are not coming to see us to buy the implants. Patients like this, they here to see us to get the teeth back. And of course, if you ask anybody what would be their priority, to have the teeth removable or fixed, most likely, with no exceptions, the majority of the patients will suggest that they would want to have the fixed restorations, and even at the immediate post-operative stage. Anyway, so we can summarize that the oral implantology, prosthodontics with the surgical elements, and what we are discussing and emphasizing or looking into, it's a part of the surgical phases that would be the evaluation of the bone and dealing with the bone and working with the bone, evaluation, the amount, and so on and so forth. The positioning of the implants we can do on the model, we can do on the skin, we can do with all the gadgets available today. But the rule is number one: when we position the implant from the tooth has to be on the distance about 2 to 3 millimeters apart, and implant to the implant say 3 to 4 millimeters apart. And the rule number two: the center of the restorative crown, again, like I said, it's a prosthodontics. The center of the restorative crown should be the center of the implant. This is just a demonstration. This is just an idea. Again, 2-3 millimeters between the implant tooth and 3 to 4 between the implants. That will give us enough bone to maintain healthy implants, to maintain the healthy soft tissue. Again, the rule is very simple. If we don't have the bone, we don't have the soft tissue. How important is the soft tissue? It's almost as important as the bone. Today, we're talking about mostly the bone. Based on what I've said, we'll do the treatment plan on the CAT scan, and now we'll need to transfer this into the patient mouth. We can use the surgical templates, we can utilize the combination of the surgical guides, or use the existing teeth which are going to be removed, but prior to removal of these teeth, we can utilize those teeth as a surgical guide. So the upper implants, the upper teeth are removed and the implants placed according to our pre-treatment setup plan. And to improve the primary stability of the implants, we're utilizing this interesting technique, intraoral welding. I'll mention the intraoral welding in a few minutes at the end of the presentation, but just notice that this is what was done in the upper jaw. The implants are placed, some of the implants are buried, because we did the sinus lift, and those implants, due to a very, very low primary stability, they will not be loaded immediately at the time of the surgery. However, they're gonna become sleepers for the time of the integration. But those implants which we managed to position in the bone and receive the good primary stability, we're going to talk about this elements in a few minutes. Those implants are welded intraorally and will be loaded immediately at the time of the surgery. That would be immediate function case. The same performs on the lower jaw. The teeth are removed, the implants are placed, predetermined position. The implants are those implants which choose to be primary loaded, that would be welded. Again, we're utilizing intraoral welding, and now you can see that there were a couple implants on the upper jaw and a couple implants on the lower jaw, which are not going to be loaded immediately due to the lack of the primary stability, or some grafting elements occurred at the time of the implant placement. However, all the other ones are rigidly connected and loaded immediately. So the patient leaves the office with the fixed temporary upper and lower restoration. So that's pretty much what the patient wanted it for the first stage. And that's pretty much what we kind of like accomplished when we could combine all the information and learn all this different technique to improve the primary stability of the implant and work with the leverage. Yes, this is Archimedes, and this is where we learn the physics and the mechanics from Archimedes, lever and forces distribution and applications. Just to mention that this intraoral welding helping us to shift the lever and improve the primary stability by rigidly connecting the implants. This is a separate topic. This is pretty much just a demonstration, the techniques to improve the primary stability, to improve the healing and speed up the healing, and facilitate bone adaptation in cases like this. Now, diagnosis of the bone density. How do we diagnose? How do we predict the bone density? We can talk about the location and the edentulous areas. We talk about the age and sex of the patients, the extraction date, general health conditions. Definitely, we can see this at the radiograph, and most definitely, and the final diagnosis would be at the time of the surgery. We're looking at the three-dimensional bone, and available bone. We'll look at the width considered to be buccal lingual distance from buccal to the lingual, and we can determine this on the CT or tomography model analysis, and we could definitely, the final determination would be made at the time of the surgery. The length, the mesial distal distance, panoramic CT tomography model, and at the time of the surgeries, and the height, of course, on the CAT scan and the periapicals and the tomography. We cannot determine this on the model, but we definitely can determine and finalize this at the time of the surgery. So with all these dimensions, the width, the length, and the height, we have a three-dimensional idea of the amount of the bone we're dealing with. Now we need to determine the density of the bone, and the density of the bone could be very well determined at the time of the surgery and based on the drilling. First, let's cover up what quality of the bone and how different the quality of the bone could be. We can divide this in the 4, 1, 2, 3, and 4 quality of the bone. Sometimes I'm simplifying at our courses. I call the good bone, the okay bone, and not too good or not too okay bone. But let's take a look at the quality one. The quality one, this is homogeneous compact bone. Quality 2, when we have a thick layer of the compact bone surrounding the core of the trabecular bone. And the quality 3, when the layer of the cortical bone is significantly thinner and it's surrounding okay trabecular bone. And the quality 4, when the cortical bone is almost absent or it's very, very thin, and now we have a very low density trabecular bone. And this is what we determine at the time of the surgery. At the time of the surgery, when we perform the drilling, we're going to look at the volume and the density of the cortical bone, and we can determine this with the guide drill, pilot drill, round drill, whatever we start our osteotomy with. The thickness of the cortical bone will tell us what type of bone we're dealing with, and the density of the sponge bone will be determined upon drilling with the starting as a twist drill, the 2 millimeters diameter twist drill. As soon as we start drilling and withdrawing the drill from the osteotomy, just by looking at the drill, if you can see the upper right corner, the white, pretty large tips, I would say that would be good to very good cortical or very, very strong trabecular bone. If the flutes of the drills are filled with the mass, the bony mass, but it's filled, you can say that this is a pretty good bone. And if the flutes are filled mostly with the blood, with the very few bone chips, that would be a poor bone quality. And based on that, we're gonna determine what would be our drilling method, what would be the size of the final drill, what would be the amount of the countersinking, do we need to tap the fixture or not, the amount of the torque during the fixture installation will be predicted, or at the same time the amount of the torque will tell us if the implant is ready for load or the implant will have to be put to sleep and we'll need to give them more time to integrate when the primary stability isn't as well. And that would be determined at the time of the fixture installation. And of course, we will determine the duration of the healing period, if it's going to be immediate or is it going to be delayed. And at the latest time, we will figure out if this has to be a progressive bone loading. At the time of the surgery, when we reflected the flap, we can estimate the amount of the bone and we can choose the fixture diameters. What I'm teaching at my courses and what I do in my practice, I'm trying to keep this as conservative, meaning like not raising large flaps unless it's necessary. How big is the flap has to be? We have to score and determine all the position of the bone, limitations of the bone at the side. But in the next clinical case, I'd like to demonstrate panoramic radiograph, the failing teeth, the failing root canals, the failing tooth structures. The teeth will be extracted and the socket preservation will be performed. Different type of, we're not talking about bone grafting as a bone grafting at the time, but we'll always keep in mind that the bone preservation must, and there is different techniques. In this case, I utilized PRF, and this is how the site looks 2 months after the extraction. It's completely healed, everything is closed. Remember that I did those extractions, so that was an opportunity for me to evaluate the residual bone, the width of the ridge, the possible fenestration or undercut area. I can estimate how thick or thin was the bone. Therefore, based on the information which was provided from the prior extraction site, I could choose in this case to do a flapless procedure. Again, a flapless procedure, I need to estimate the width of the bone, the undercut position, and also the height of the bone. Due to the insufficient height, also sinus lift, internal sinus lift, was performed at the time of the surgery. So let's summarize. We did flapless procedure, immediate implant placement, immediate sinus lift, and all this done in one procedure based on the information which we gathered at the time of the extraction. What's the advantages versus disadvantages? Yes, it's a little trickier. You work a little bit blindfolded. based on the information from the prior appointment, you can do flapless procedure. If you're not comfortable with this, you can always raise the flap. And also when you drill and you feel that something is not happening the way you would want it to be, you might need to raise the flap to concur that the position is proper. In this case, it didn't happen. So in 4 months, the case was pretty much successfully restored, and happy patient. Another case, it's a completely different case. Sometimes I have a patient who do come to the office. As a matter of fact, as we started from the first case, when I started the presentation, the patient come to the office, and all they want the fixed teeth, and they want the fixed teeth today. They don't want to think or talk about the future. Anyway, this is the preoperative radiograph. As you can see, there are some retained roots. These teeth are pretty stable, but they do have some periodontal issues. Therefore, the patient's suggestion was, can I get, and he has a very, very uncomfortably fitting RPG, removable partial denture, with the metal hooks, clasps, and so on and so forth. The patient request was, can I have some fixed prosthesis, and can I have this today? Oh, absolutely. We don't say no to the patient. I mean, not always. Sometimes not. Anyway, the bone width will be determined at the time of the surgery when the patient is anesthetized. We're using caliper, and we can see the available bone and the arterial ridge. And as you can see, is not as much as we would want it to have. So there is certain area with very limited bone, and then we need to make a decision. Are we going to graft it? Are we going to avoid this? Do we need this area? Can we spread the implants on the sides and get away from this thin ridge and restore this somehow some differently? If you remember from the preoperative photographs, and of course we do some kind of model work, this patient has a class 3 occlusion. The class 3 occlusion proposed that the overject would be of the lower teeth, or overjecting the upper teeth. We definitely need to notify the patient prior to the procedure, and we can pretty much bring the patient to the edge-to-edge situation. Okay, the teeth are extracted, the bone is exposed, and now to bring the teeth into the edge-to-edge from the class 3, we need to reduce the diameter or the radius of the curvature. And therefore, in this in mind, we need to do this at the time of the surgery. So we need to figure out what would be the proper implant position. So the implant position, definitely, we're not going to be able to place the implant in the same position where the teeth were. So now we're going to avoid the sockets, and we're going to find the bone in between the sockets or the side of the sockets to reduce the curvature of the arch. Therefore, gives us the possibility to bring the teeth in rather than bring them out. The implant position, the abutment position, and now the patient leaves the office with the fixed temporary. Again, what's important in this case? The drilling, all the information of the bone quality, the bone quantity, and the amount of the bone, most of it was done at the time of the surgery. So the drilling technique, it's a very, very valuable examination. And this is the final restoration. And this is post-op, as a matter of fact. So we can see that the bone maintained, and the patient is pretty happy. And again, cosmetic was not a patient concern, as long as you can chew and not removing anything, to have this denture full-time in the mouth. That's what makes this patient happy. So let's take a look at the alternative solution when we can utilize alveoloplasty as an bone treatment element. The triangular shaped bone cross section, we can see that if the height of the bone is not important cosmetically or prosthodontically, if we choose for the patient to have, in certain situations, I do this less and less, but in the certain situation, if we choose for this patient to have overdenture, then we do need to provide the space for the overdentures. In a situation like this, rather than split the bone or do GBR or do the the block graft procedures, we can do alveoloplasty, and by removing the bone, instead of grafting the bone, by removing and shaving the bone down, we're going to gain the width of the bone. Of course, if you don't have certain limitations like the nerve and the sinus, this procedure might be vital. But again, in mind, what we have to have is what would be the final restoration. I do less and less of this procedure, but sometimes it has place to be. When the patient like this present to the office, and very unhappy patients, and what do we call these teeth? We call them the cup teeth, we call them the pocket teeth, we call them gum covers. And why is the patient unhappy? If we'll do the intraoral evaluation and the panoramic examination, we can see that the ridge is very, very narrow. It's pretty sharp. It just has a little band, a fibrotic band on the top of the ridge, but the ridge is like so sharp, it cannot retain the denture. There is no way, in my mind, this patient could be happy with this overdenture over this ridge. So we're utilizing the denture, the patient's denture, as in radiographic markers, and we're utilizing the pre-existing denture for the treatment plan and to predetermine the future implant position. If you'll take a look at the ridge, you would understand. I mean, there is no way this patient can wear comfortably the lower full denture. So what do we do? As I described before, we go with alveoloplasty to the point when the width of the ridge becomes successful to bear the implants, and we place 4 fixtures utilizing the interchangeable healing cups. And again, remember, once we did the alveoloplasty, we have the bone in, not the bone, we have the soft tissue in excess, and we do have to gain some keratinized tissue. So utilizing some plastic surgery techniques, manipulating the soft tissue, and interchanging healing cups, healing abutments, whatever you want to call them, get a pretty decent result. So now we have the width, and now we have very good keratinized tissue. Again, keratinized tissue is a must. If you want to have a long, good term successful results, the keratinized tissue is a must. The prosthetically, that was elected to have a overdenture for this patient, and this is the overdenture with the Swiss plunger or loop passive attachments. It's fitted in the mouth. So this is the patient before, and this is the patient after. You can see the big difference, the life quality. It's not the same shirt. Somebody mentioned that it's not the same shirt. Take a look at the pattern. But this is the same patient, but the face is completely different. So all he could do before is just to look at this and salivate. And right now, with whatever we created, I mean, it takes them a few seconds to clean it up very, very, very fast. And see, now we know why do we call this T-bone steak. This is the patient, the same patient 5 years after the surgery. The proper position, the proper load, the main elements of the prosthodontics, and a sufficient amount of keratinized tissue, which make this very maintainable. That's a pretty good result in the 5 years. There is an alternative, not alternative, but different techniques for the ridge augmentation. If you have a narrow ridge, we could choose 1 or 2 procedures to augment it. GBR, it's a guided bone regeneration, or we can choose the block bone graft. Both of these techniques are meant to increase the ridge width. There would be one more which we discuss later. It's a ridge split, which is my favorite. Here's the situation when the patient presents to the office and everything is done for this patient. And the root planning and scaling is done. The root canal therapy is performed. So I think it's a good time for this tooth to come out now. But the problem is we kept this tooth, or they kept, or whoever kept this tooth for a bit too long. We've lost a lot of bone. So the procedure like this, it's not always predictable, but with the proper techniques, we can get a pretty good results with the bone grafting, and that would be the GBR procedure. And we can get pretty nice results, and this is a 5 years post-op. In the situation like this, we're going to take a look at the GBR procedures in details. Again, the patient presented fractured, infected root, pretty narrow ridge, and there is a couple of different approaches we can treatment plan this patient. The one which chose in this situation, the tooth was extracted and the implants were placed. Now we can see the insufficient amount of the bone, and some of the fixtures are not even covered with the bone. Somebody would say, oh, we can do the ridge split. Yes, we can, but we're not going to generate the height. The ridge split is when only the height is present, but not the width. In this situation, there is limitations in the width and the height. So that would be the indication for GBR technique, and we're going to use particulated bone graft with the membrane. That's how this situation will be solved. As an alternative to the narrow ridges, we can utilize the small diameter implants or mini implants or narrow implants or implants for the narrow ridges. The diameter of those implants would be 2.5 to 3.5 millimeters, and they do come in one-stage implant or two stages implant. The majority of the cases, the implants I would use, it's a one-piece implant, and this, you have to keep in mind that this case will need to be loaded immediately. And again, certain protocols need to be followed with the immediate implant placement, and the certain prosthodontic consideration needs to be taken. But this is a valid technique for the narrow ridges. I would say the most common in my practice, it's only anterior mandibular, only anterior mandibular. That would be the best solution for the situation. Split technique, when we need to enhance the width of the bone, and the height of the bone is sufficient, but the width is not. We can split the ridge. Let's take a look at the situations where we could utilize this technique. It's a pretty narrow ridge. You can determine this intraorally, and by splitting the ridge, we can maintain the height of the ridge. We can increase keratinized tissue. There are certain techniques by grafting or using secondary healing, by splitting, we can gain the width. Sometimes we can split it up to 3 millimeters. So you can figure out the diameter of the fixtures could be corresponded. And again, as you can see on this slide, on the right slide, that there is a sufficient amount of the buccal and the lingual bone. The ridge could be split with the special chisels or rotary instruments. Depends what's the preference. And I'm utilizing the rotary instruments, the ridge splitters, the implant positioning, and again, we'll take a look at the ridge. Insufficient width, but height. Again, the ridge is splitted, the implants are placed, and this is a healing with enhanced amount of the keratinized tissue, and this case is successfully restored. So this is one of the techniques. I know it's not the Halloween, not just yet, we're not even close, but look at these guys, look at the masters, look at the carving technique. I was wondering if we can get one of those guys in implantology, what they can do with the bone. I mean, this is a chair-side carving. They can do fantastic things. All right, that would be at the joke level. Solution for insufficient bone. Insufficient bone vertically. We have the width of the bone. We don't have the height of the bone. On the upper jaw, we can perform the sinus lifting. On the lower jaw, we can do mandibular nerve repositioning. We can do the bone grafting. And we can use the short wide fixtures. We're going to look at all of these elements, but let's take a look at the sinus lift. Patient presented with the large periapical infection, and after the tooth was extracted, we still determine it's not very well visible on the panoramic. Therefore, we can get the CAT scan for this patient, so we can absolutely certainly say that he has a cyst right in the area where we would want it to lift the sinus. It's very, very important not to not acknowledge this. We need to determine if the cyst is over there, because that might be an issue when we're going to place the implant. There are certain techniques could be utilized when we can aspirate the tissue, the cyst, do the sinus lift and place the implant immediately. So for insufficient height. Again, after predetermination or determination, clinical and radiographic examination, the patient has insufficient bone height and has a sinus, and the sinus is clean, no cysts, no polyps, and the ostium is open and working properly. We can perform the sinus lift. The sinus lift could be done through the lateral wall. We call it lateral wall sinus lift, or there's different names and different techniques for either intercrestal, subcrestal, or internal sinus lift techniques, and this procedure would look like that. So we can lift the sinus sometimes up to 10 millimeters. We have situations when we've done it too. again, like I said, different techniques could be utilized, but one of the first, our pioneers, Professor Linko, Dr. Linko, he acknowledged the possibility of the lifting sinus membrane. It's almost like kind of like an accidentally, the membrane was touched and lifted and moved with the blade implants, and later on at the later radiographs, it was determined there's like some interesting bone opposition against the implant. So that's how the first facts of the internal sinus lift was kind of like described. But at later dates, Tatum and Summers and Shepard developed this technique in details, and then different gadgets were used for the internal sinus lift, and as well as Dr. Linkop described the internal sinus possibility of the internal sinus lift. He developed the whole idea of the lateral wall sinus lift, and those are the facts. Those are the different implant modalities, the root forms and the blade implants utilized with the sinus lift. And this is just one of the clinical presentation of the immediate implant placement with the tooth extraction and implant placement, and again the sinus lift. There is a different gadget, different modalities of the different techniques could be utilized for pretty successful. Again, it's not the easy procedure, but it could be done pretty successfully after the certain training is performed. The short and wide fixtures, that would be the options when we don't want to do the sinus lift. Not always we want to jump into the sinus and do the sinus lift. There are certain limitations. It's a serious procedure, and if the pre-operative examination was not done successfully, if something is missing, it might lead to the pretty serious complications. So if it's an older patient with the complicated medical history, I would probably prefer to do something more conservative, and I would utilize the wider and shorter fixtures, and pretty much you can get a good success. Let's talk a little bit about the lower jaw. The lower jaw procedures for the lower jaw, the limitations again, the width and the height. In this case, presented here, have a very narrow reach. Patient presented to the office and is a very nice guy, and as a matter of fact, recently, not recently as of today, but recently from the time when he presented to the office, he was diagnosed with the Parkinson. So picture this guy with the denture. First of all, they don't stay. There is no glue in the world which can hold the denture in a situation like this. And the next step to look into the overdenture, possible overdenture, like the case I've demonstrated before with the blue passive attachments. Again, I said the guy is developing Parkinson. He's not going to be able to manipulate with the hands and the mouth. So we need to do something a little more practical. It could be some kind of like ball attachments or locators or similar to. Or in this case, what we decided to do is we decided to do the fixed prosthesis. So the guy who is planning to suffer for the rest of his life, at least not going to suffer much from being dental crippled. For the panoramic radiograph, we're utilizing the markers, prefabricated ball markers, to determine the vertical and mesodistal distance. Also, we could do the radiographic markers utilizing the patient's dentures, and this is what it's going to look. That help us to locate and identify the nerve, and also it will help us to identify and locate the proper implant position, because this is nothing but the surgical guide. And between the foramen mental, again, going back to the x-rays, going back for 1 second to the x-rays, we can see that endoosseous implants would not be an indication in this case, because we don't have sufficient bone height behind the foramen mentale, but we do have some on the anterior area. Therefore, how many implants we can fit between the foramen mentale? We can fit from 4 to 6 implants, and I will demonstrate this without jeopardizing the nerve position, assuming that we can locate the loop and successfully place the implants right before the loop without touching the nerve and without patient getting numb. Again, the implant placement, we've determined, we've checked on the periapical, the implant is successfully placed without touching the nerve. And this case was restored immediately with fixed prosthesis and later replaced with the permanent fixed prosthesis. It's not the ideal situation. It's not what I'm advocating, but unfortunately, yes, we do have situations when we have to use this as a modality for this type of patient. By stabilizing the lower teeth, we can pretty much follow the elements of the proper prosthodontics and occlusion. We can pretty much make the upper denture much more stable with the cantilevers on the lower. Again, this is another patient, very similar situation. The patient presented to the office, and we need to do this pretty much almost at the time of the patient presented to the office. Again, we're utilizing not always the denture as a marker. Sometimes, if it's not fulfilling information on the x-ray, what we could do is we can determine the nerve position at the time of the surgery. So this is a pre-operative assumption where the nerve would be, and then at the time of the surgery, we're placing 6 implants are placed, but the most distal implants, before we position them, we did determine, we dissect the nerve, so we've got the nerve position, therefore we can place the implants are pretty successfully without damaging the nerve and in a very close proximity to the nerve. So that is done again at the time of the surgery. None of this patient get now. There might have been some very light temporary paresthesia. It's a possibility, but again, very close proximity to the nerve, and again, it's a fixed prosthesis. One of the other options that would be the either nerve reposition. Again, in this situation, we did the sinus lift, but we discussed it already. So let's take a look at the lower left side. It could be either nerve reposition, or in this case, we've elected the lingualized position because this patient had a tori mandibulare, and again, we've determined the position of the nerve, and closer to foramen mentale, the nerve position is much more buccally versus the distal proximal side of the mandibula. We have sufficient amount of the bone lingually, and that's where the implant is placed, again, without jeopardizing the nerve. Let's summarize, let's recap. Short fixtures, number of the fixtures, surface treatment fixtures we can use for the insufficient amount of the bone to improve implant integration. We can use the fixture with the calcium hydroxylapatite, which supposedly in literature described that increasing the surface by treating the surface, we can improve the implant integration. Again, sinus lift, we discussed mandibular nerve repositioning or lingualizing implant position and the bone grafting. Very thorough examination. Let us, especially CT examination, gives us the opportunity to place the implant in a very close proximity with the nerve. I'm not advocating to do this, but sometimes we do things like this. It doesn't make our life any longer. But there is a possibility to get pretty close to the nerve without damaging the nerve. It's very, very, very accurate surgical techniques, very, very gentle. Let's get back to insufficient height and presence of the basal bone rather than alveolar bone. Remember that we have alveolar bone and we have a basal bone. What is the difference? Alveolar bone grafted, and we can get better results with the grafting techniques or splitting technique because the alveolar bone, it's a lot better vascularized bone versus the basal bone, dense bone, less vascularization over there, less blood supply. Therefore, grafting procedure are not going to be as successful. This is a combination, both sides pretty tough, but one is 3.2 millimeters before the nerve, the other one is 6.7. In this case, what we choose a different implant modality. It's a subperiosteal implant. Unfortunately, there is no classes in the States, or pretty much almost nowhere but Italy, where you can learn this technique. It's a subperiosteal implant, and it's a pretty vital technique. We can solve the problems. As a matter of fact, this patient was very young. At the time of the surgery, he was about 57 or 58, and he suffered prior to the surgery for many years of the inability of chew food or retain the prosthesis. Bilateral, unilateral, bilateral subperiosteal implants solve the problem. And you can see on the CAT scan, you can see very, very nice adaptation of the metal struts to the bone after 7 years post-op. So that's one of the modalities which could be utilized for insufficient bone height. You need to have a certain indication for certain type of the implants. In this case, we're talking about purely basal bone. The implant is for the basal bone. Now, let's take a look at this. I borrowed this from my colleagues. What can you say about this X-ray? I don't want you to criticize the dentist. Let's be good colleagues. I think, actually, I'm not going to even continue on this. I just add that probably a little bit more time should have been spent for the treatment planning of this case. And therefore, this one, however, slide, you can criticize, you can say whatever you want. And we're not talking about this person as a dentist. We're talking about as a driver. So you can use whatever the vocabulary you want in your mind, of course. But the driving with the low tire, 110 miles, it's a little tricky. Anyway, that would conclude our webinar for today. What we could do is, again, just so you know, we do have seminars, practicum seminars, when we teach the doctors to do the surgical implant procedures and prosthodontic procedures on the patients in our island classes. And if anybody is interested, the information is on our website.